We're excited to have you back for our second panel here, which will be, I think, fantastic. So with that, let me turn it over to Ziad Obermeyer, the professor in the Berkeley School of Public Health, who is going to moderate our next panel. So with that, take it away, Ziad.
Thank you so much, and thank you. It's such an honor to be, even if I'm the least accomplished and intelligent person on this panel, it makes it even more of an honor to be moderating it. So I teach at the School of Public Health at Berkeley, and I'm just going to tell you a little bit about our panelists first, and then what I thought I'd do is tell you a little bit, just one story from my own work on algorithms, where there is both a lot of innovation and not a lot of regulation, because I think it's helped me think a little bit about how to think about that trade-off elsewhere. But first, let me introduce our esteemed panelists. Matt Grennan, while he is an assistant professor of healthcare management at Wharton right now, it is wonderful to know that he is actually moving to Berkeley, and we're really excited to have him here. Matt teaches on healthcare entrepreneurship, management and strategy, and has done some really exciting work on medical devices and on analytics. And published in many esteemed publications, AER, JPE, Management Science, and it's really wonderful to have him here. Amitabh Chandra, I see Amitabh several times a week, where we routinely torture each other in the course of writing papers. But Amitabh also does a lot of other important stuff with the rest of his time. He is the Ethel Zimmerman Weiner Professor of Public Policy, Director of Health Policy Research at the Kennedy School at Harvard, the Henry and Allison McCann's Professor of Business Administration at HBS. He is also an administrator. He directs the MS-MBA program in the life sciences, and has done a lot of amazing work at the CBO, for example, but also on the research side, and has published in more places than I can name. And Fiona Scott Morton is the Theodore Nierenberg Professor of Economics at Yale at the Business School, where she has done some really important work on consolidation, on procurement, on pricing, and also has worked as the Deputy Assistant Attorney General for Economics in antitrust, enforcing the nation's antitrust laws. So with those esteemed panelists in mind, I thought, let me share a story just from the past couple of years of my work on algorithms, because I thought it might be a good place to start, at least it was for me, thinking about innovation and regulation. And where I started thinking about this was that, it's a trade-off, and it's very natural to think about it as a trade-off. And Matt, your work has shown that directly, looking at the trade-off between uncertainty, knowing enough about a product to approve it, while at the same time not wanting to stifle innovation and getting those products to market to begin with. And so I was wondering if there was any way to start thinking about this as not as a trade-off, but as a win-win. And part of that comes from my work on algorithms. So there's an enormous amount of innovation in this space of using algorithms in healthcare. The place where that's gotten to the largest scale is in what I think of as kind of policy decisions in healthcare, which are like, I've got a population of patients, some of them are going to get sick. I'd like to know which ones are going to get sick so that I can help them today. So, if you take the industry estimates seriously, we studied one piece of software that was being used for 70 million people a year. The industry as a whole believes that it's used, these algorithms are used to screen the majority of the US population. So like up to 150 or 200 million people a year, basically to target these extra help interventions for people who might get sick. So we can help them, keep them out of the ER, make their health better, keep costs down. And so that is a good thing, and we want innovation in this space. Doctors are not proactive. Health systems should be more proactive. We want them to do that. We actually think that algorithms might be very good at predicting much better than doctors are about which patients are going to get sick. The problem was that these algorithms had an enormous degree of racial bias. the algorithms were favoring healthier white patients over sicker Black patients because of an error. That algorithm family, we studied one instance of this whole family that all did the same thing. It predicted how much someone was going to cost in terms of their healthcare as a proxy for how much healthcare they were going to need. But of course, not everybody who needs healthcare gets healthcare. And that bias is built into the proxy measure that the algorithm was predicting. And because conditional on health, Black patients on average cost less, as do poor patients, rural patients, anyone who is discriminated against or lacks access, these algorithms were deprioritizing Black patients for this extra help program. So, here are three things that I learned, and then I'd love for you guys to not necessarily react to my little story, but tie this into kind of like some bigger themes that you have all researched so well. Point one: so much innovation on so many important topics, and that's great, but it can go wrong very easily, and the market doesn't catch it. So none of these companies knew that they were putting out a product that encoded racial bias. None of the hospital systems that purchased the algorithm found it. None of the doctors or patients that had this algorithm impact care found it. So there's a clear market failure, even though we want innovation. So I think that sets the stage for discussions about regulation. Point number two: that problem can actually be fixed. So we worked with the company that made that algorithm to retrain the algorithm to have it predict health outcomes rather than cost outcomes. And that really dramatically changed the racial composition of the high priority group. I would say that also made the algorithm work better for its intended purpose. So all these algorithms were predicting total cost. That conflates like insulin, which costs money, with a toe amputation, which also costs money. Some of those costs are good, some of them are bad. So by retraining the algorithm to predict something that was more aligned with the business purpose to begin with, we also made it less inequitable. And so that's really what made me think, as we work with, for example, the FTC to build this insight into guidance for industry. We work with health systems and insurers to help them inventory and fix their algorithms. Are there places where regulators can, by setting the target properly for regulation, this is the kind of thing that we want algorithms to produce? In the same way that we do for drugs, we say these are the treatment effects that we will approve your drug based on. Can regulators, by setting the target for regulation properly, both point companies in the right direction and encourage innovation on the right metric, and also let us value that innovation effectively? So when we're approving drugs, when we're approving algorithms, setting the right target seems to have this huge effect for spurring innovation, but also limiting the downside risk and the uncertainty, because companies know that they need to produce exactly innovation on that direction. So let me stop there. I'd love to get your perspectives on this in any order that you guys think. I know that it highlights a lot of themes from some of the topics that you've all worked on. Maybe Matt, it's most closely related to things that you've worked on. So if you don't mind starting, that would be great.
Yeah, sure. Happy to start, and thanks, Ziad, for the great and I think stimulating introduction that as you say, is related to a lot of core issues in this area that we're going to be talking about in this panel. I mean, one of the things that came to my mind as you were speaking there that I think is a big challenge for innovation and regulation of innovation in healthcare is the fact that, a lot of healthcare is what econo nerds would call a credence good, right? So meaning that it's a good that it's very difficult to know upfront exactly what you need, and it's even difficult afterwards, after you get it and try it, to know if what you got was what you wanted. So the simplest idea being you go to the doctor with some sort of flu/cold thing, and you maybe get prescribed an antibiotic, and often you never really know. You get well a few days later. You never really know if you would have gotten well without that treatment, or if you really needed that treatment, or if the doctor choosing to give you that treatment was kind of the best thing based on the evidence that was available at the time, because there's just a a lot of pieces of uncertainty in healthcare, and we go to physicians as patients because we don't have a lot of the expertise we need to assess everything that's going on. And where this comes in with this issue of innovation is that it makes it really hard to assess the quality of a lot of innovations, and that one of the ways we try to address that are with things like say a clinical trial before a drug or a device goes on the market. But those are always kind of inherently limited, and they're very costly in terms of money and time. And I think one of the things that we often are running into, which your algorithm example I think really brought out well, was the fact that we're not assessing these things in an ongoing manner on the back end. And I think part of that is probably a policy problem, and that we haven't made that a huge priority. And part of that is also probably related to some of the discussion in the first panel, in that we have probably a data problem in the United States, and that because we have this system that's quite fractured across different health information technology providers, different payers, et cetera, it's often hard to get a great data set that's going to allow you to track some of these things on the back end too.
Yeah, so I think that's exactly right. Is that so often in not just in healthcare, but in a lot of important social sectors where we want to use data, we don't actually measure the thing that we care about. And this comes up, I've seen this a lot in different places where algorithms are applied. For example, in criminal justice, we want an algorithm that's going to help a judge make a sentencing decision based on someone's likelihood of committing another crime. But we don't see someone's intrinsic propensity for crime. We just see if they were arrested or if they were convicted. And those things are very, very different, given all of the problems with the data generating process for criminal justice data. Fiona, I probably touched on, you've worked on so many things, and I've probably touched on corners of many, but one place that occurred to me that there could be a win-win is actually precisely in the competition across innovators, and where people can actually, where the marketplace is set up in a way that favors competition on the right thing. It feels like that can be a really productive place where regulators can both regulate and also drive innovation. So that was one theme that occurred to me, but many others probably occurred to you.
Yeah, it's really hard in healthcare because innovation competition is probably one of the most important sources of consumer welfare benefits across many, many industries. But when you've got governments setting the terms of what they're going to pay for, the government's not going to say, well, we'll pay an unknown amount for anything you might invent in the future. Now, actually, in the United States, we basically do that. You set the price, and if a doctor decides it's medically necessary, the taxpayer will pay for it. And once you understand that that's the way it works, you're surprised we only spend 20% of GDP on healthcare. I mean, and why marketing to doctors is so important. So it's very expensive to incentivize innovation the way we do it. I'm more fond of the nice approach, which is go out and innovate, but if what you deliver is an extra $60,000 worth of cost to the pharmaceutical product, and on average somebody lives 6 more days or 6 more weeks, then actually that's not really a good use of money, and we're going to spend our taxpayer money on something else. And we don't have any kind of cost effectiveness standard in the United States, and so we just buy everything, no matter how costly it is. And I think that just leads to a ton of wasted money. But why do firms invest in those areas and innovate in those areas? Because we pay them ridiculous amounts, and we don't have any way of paying firms to innovate in areas that might actually produce more low-hanging fruit, but are not, the business model is not set up so that would work. So for example, if you're a surgeon and you find a better way of doing a particular surgery, there isn't a way to patent that or trademark that or disseminate that in an efficient fashion. And so we probably have not enough research into what are better ways to do surgery. An example of innovation that I encountered accidentally by moderating a panel here at Yale some years ago was a manager from a small HMO who was talking about how they were thinking about taking capitation for different kinds of services. And the one that he spoke about was hip surgery and hip replacements. And he said the thing they'd taken capitation in a few different services, and they studied them and figure out whether they could make money. And in the hip replacement case, he said the problem was the skilled nursing facility was such a huge part of the cost, and we didn't own a skilled nursing facility. We owned doctors, well, they owned, I think, a hospital or some other stuff, but not a SNF. So that was going to eat up all the profit. So he said what we did is we took a look at that hip replacement surgery, and we figured out if we sent a nurse to the hospital to help you learn to do rehab before you left, and then we sent a nurse to visit you at home and look after you and do rehab at home, we could entirely skip the skilled nursing facility. We just left it out. And so they took capitation, they took the patients, they made lots of money, and nobody was needing to go to the SNF where, in fact, it's expensive and you get diseases and so on. And health outcomes were just as good. How do you incentivize that kind of innovation, that organizational change sort of innovation? And what was funny to me about this was it was incentivized by the fact that they didn't own the relevant asset. And so how you set up your healthcare system, who owns what, and even though you might say, well, surely the SNF, even if you owned it, you would have wanted to save all these costs. I'm not so sure. The SNF has a manager who's responsible for the bottom line of the SNF, profit and loss. They're going to be sitting at the table. If the normal thing is that a patient comes to the SNF, that person's going to object if the patients aren't sent to the SNF. So we have this interesting interface of culture and economics where the human being at the table and the configuration of the assets determines the kind of ideas that we have. And I think that's really an interesting problem. And I don't think it's only the United States that has this problem. You have a way of doing things, and there isn't inherently tons of organizational variety and change, and it's really hard to learn this stuff.
Fiona, you mentioned a lot of things that I think resonate with some of Amitabh's work, and I know one paper that comes to mind, Amitabh, is your paper with John Gruber and Robin McKnight about how there are these cost offsets, and so a plan can save money paying for drugs and stick someone else with the cost of the resulting hospitalizations. And so there are all these cases where this fragmentation is counterproductive. But as Fiona, you pointed out, it's not necessarily the case that just lumping everyone together is going to fix that problem. And so, it feels like if there were some way to get more of that that dynamic that you mentioned about, the hospital wants to save money on the SNF, and so they're going to innovate to cut them out of the market and take some of that money. Like, Amitabh, I think the solution that some people would say is like, yeah, single payer is going to solve all these problems, but I think that some of your work suggests that even though fragmentation causes problems, consolidation isn't necessarily the solution for those problems.
Yeah, well, we were looking at Medicare, which is the single payer system. So whatever was going on in Medicare was clearly not the best way to save lives. But I think, to build on what Fiona said, when we talk about innovation in pharma, we're often thinking about new drugs. But what you're getting at, Ziad, is there's a variety of other innovations in the drug space that probably don't happen. One of them is innovation in plan design, right? So people have a lot of trouble being adherent to their meds. And people will say, well, it's all cost sharing. I mean, you and I have a paper that says cost sharing kills, but we also know that cost sharing is not the only impediment to taking your drugs, right? Like even if I waive all the copays, we have very good RCT evidence that adherence goes up, but it goes up nowhere near the 90-95% rates we need. There's a deep behavioral bias that we have not seen innovation in overcoming. The NHS folks will say, well, waive the copays. That's great, waive the copays, right? And that's an improvement, but that's how do you make the drug salient enough to the patient, easy enough to take to the patient, that they actually take the medicine? So that's one kind of missing innovation, I think, in the pharma space. The other one is just prevention, right? So think about, this is kind of building off a point that Fiona made. Just think about Alzheimer's. We don't have a great drug for Alzheimer's, but we also don't know really how to prevent Alzheimer's, but no one has the incentives to discover how to prevent Alzheimer's because there is no intellectual property probably on that discovery. It's going to be impossible to appropriate this it could be worth trillions and trillions of dollars to learn that if I got 9 hours of sleep in my 50s, I don't get Alzheimer's in my 70s. No one's going to do that research, right? So you can see how we're over-centing, there's an allocative inefficiency here. We will pay handsomely for an Alzheimer's drug that has a very small signature on cognition, on functioning, but we would not be willing to invest $20 billion to figure out how much of Alzheimer's we could prevent. And this is a worldwide problem. This is not a uniquely American problem. So I'd say that's the second piece of the innovation, kind of the innovation in the pharma space that's missing. The third, and I'll stop talking, Ziad, if you tell me I've overstayed my time, is I think clearly when it comes to new drugs and the problem of new drugs, clearly patents matter and exclusivity periods and intellectual property matter, no question. But I think there's just a raft of other barriers to transformational drugs coming to market, like insufficient basic science investments in Alzheimer's, right? Or you take something like insulin. We've been arguing about the high price of insulin for 100 years. But the point is, we're still treating diabetes with insulin. We're not using cells as medicine. We're not saying, let me reprogram the beta cells in your pancreas to secrete insulin. By the way, that would just be like a cure for diabetes. Why don't we do that? Probably because we don't invest enough in stem cell research. And when we do, suddenly, I think the executive branch will come in and say, well, we want to have nothing to do with stem cell research. But I think that becomes, what that means is companies have a strong incentive to innovate in the existing structure, but society might want this transformational innovation, which might be cheap to access, actually, right? It might just be that if you doubled or tripled the NIH budget, you would start to see many more of the double or triple, not one time, but permanently, you would have de-risked that kind of science. So I think I'd love to kind of talk about the parts of innovation that are working in drugs. But I think my own take is we're not getting nearly as much transformational innovation as the science is capable of.
And can I just pile on with one other organizational thing that builds on what Amitabh said? I think if you wanted to reduce the incidence of diabetes, there are very good ways to do that through diet. And if the nutritionist comes to your house once every 6 weeks and yells at you and cleans out your pantry and reminds you what to eat and so on, that's more effective than drugs. Do we do that? No, because the whole system is set up. The doctor has 6 minutes with you. It's just easier to push out a pill. The pharma representative is visiting the doctor, marketing the pill. The pharma benefit pays for the pill. Nobody's interested in paying for the nutritionist. That person might be more expensive. By the time you need the toe amputation, you're on Medicare. So why should the insurance company bother anyway? And there's a whole bunch of ways in which we set up the incentives and structure that innovation of that kind, where you're comparing the drug to the nutrition intervention, doesn't even happen.
Yeah, such great points. And sorry, Matt, you had something to add.
Oh, no, I mean, I was just going to add, I'm not sure, where this space is going to go, but, one area where a lot of, I think, potentially related solutions to these problems are being tried out is the digital health space, right? And it's all pretty new. And who knows, how widely it's going to be adopted or how they're going to be able to figure out how to actually make businesses out of this or get it to a lot of people. But it is an area where people are trying to solve a lot of the problems we've just talked about.
And a couple of examples that I just wanted to mention and maybe get you guys to react to, because I think they bring together a lot of the themes that you've brought up. So one is a positive example and one is a kind of more pessimistic one. So the positive example is that I think one place where we're seeing a lot of innovation is in the Medicare Advantage space because, as the theory would predict, they are incentivized to do things properly. And so, a couple of things that I've seen recently is that one of my friends runs a big Medicare Advantage plan in LA. And one thing that he's realized is that he cares for a lot of low income people. Some of them are either long or short term unhoused people. And those people have very high comorbidity burdens, and actually, they're quite they're not necessarily lucrative for the plan, but at least the capitated rates are pretty high. And so the thing that he's realized and is starting to invest in is just giving them housing, and that turns out to be a good deal for him to do in the context of an MA plan, because it just keeps them out of the emergency department and the hospital and things like that. I also had I've been trying to convince a lot of people to do the following thing, including my friend at his plan, which is that, to your point, Fiona, on non-pharmacological interventions for diet, now that we have meal delivery services that can literally prepare a meal to your specifications, very low carb, no problem, tasty, yeah, they will show up at your door and they will just make it easy. I think that's the problem with the nutritionist and the exercise and you should eat low carb, is that it's not easy. And if you want people to do something, just make it easy. So what is easier than food showing up at your door that tastes good and is custom designed for your diet? So can we get Medicare Advantage plans to just do that for their diabetic patients? Maybe. Can we also use that to drive forward the science of nutrition? I think so, because the whole problem, the reason that 1 week coffee is good for you and the next week it kills you, is because we can't do this. We can't exert this level of control on people's diets. So I think that's kind of on the very positive side, where I hope we're going to start to see innovations like that coming out. But I think that COVID gave us so many both examples of the miracles of science and the economics behind that science, and also the failures that I wanted to maybe also cite the some of the weird things about that. So testing is something that actually John Kolstad and Ned Augenblick and Al Wang, who's a PhD student, worked on. We came up with a great way to improve the efficiency of testing kind of computationally. And we, mostly John and Ned, worked for a year trying to get a lab to do it. And we just could not persuade anyone to do it, even though it would have dramatically reduced the cost of testing and increased access to testing. On the drug side, of course, the vaccines have been, such a huge success story. But I've been really surprised recently at the headlines that are like, oh, these pharmaceutical companies are making so much profit, it's terrible, when in fact they've captured such a small fraction of the value that's been created. So we should have been willing to pay orders of magnitude more to anyone who could get us out of this mess. And yet for some reason, we kind of weren't. And when we did, we're still kind of angry about it. So that really struck me as just like a weird example of some of the dynamics that, especially Amitabh, you were talking about. It's like we kind of, as Fiona and Matt, you were saying, we sort of pay for the wrong things and we measure the wrong things. And then as Amitabh was saying, it's like, even when we don't, we're kind of like, we don't want to pay enough for those right things.
Yeah,
and so
I think, can I jump in on testing? You're so right. And I think one of the issues there was a significant uncertainty about what the federal government was going to do, about the progress of the disease, about the arrival of the vaccine. And we had at the time, at least in my view, a totally incompetent federal government. And what you really needed was a government that internalized all the costs on society of this virus and said, right, we are going to procure right now this many billions of dollars of testing machines and this much capacity to do instant tests at schools and restaurants and wherever. And if that had happened right up front, then the testing companies with a guaranteed order, the folks who make that equipment wouldn't be worried about building capacity only to have the virus disappear and not make any sales. And maybe we would have spent a lot of money and not needed those machines, but wouldn't that be a good outcome? I mean, if we've spent all that money and the virus went away, you hope that that's what happens. And then if it's bad, you have that capacity in place. So I just think we can't rely on the private sector to internalize all the risks and externalities that we bear. And that's why we have a government in the first place, and we need it to do that.
And I mean, we have that playbook ended up working very successfully for vaccines. And so I think for me, it's just kind of a mystery that it didn't work for other things. I mean, like testing, exactly as you're saying, we could have run that same playbook and just committed in advance to paying for testing. We did it for vaccines, even though it was the same administration, same profile of positives and negatives. But yeah, it seems like there was just some other things going on.
I mean, there's the rest of the world. I think that's part of why the vaccines worked. Testing is naturally local. You have to test right there, and it has to be quick. But the vaccines you're going to sell to the rest of the world, and you're going to keep selling them for many, many years.
Yeah, that makes a lot of sense. Amitabh or Matt, COVID kind of stories, positive, negative, that make some of the points that you've already alluded to?
One thing that I think is something that's worth exploring as one of these barriers to, one of the causes of missing medicines is just that I'm thinking of Raj Shetty's work here on Lost Einsteins. There are a lot of people who just don't go into the life sciences, right? And they don't know about the life sciences, so they don't go into the life sciences. And that becomes a big source of missing innovations. Like if they had gone into the life sciences, then maybe we'd have, we'd have more ideas for companies to pursue. And I think that's something we haven't really explored. Like in the world today, there are if you look at the 4 cities that lead the world on patenting in the life sciences, or you might say, I don't care about patents, I care about papers in Cell and Nature. Those cities are like New Haven, Boston, the Bay Area, and New York. A city like Chicago, London, Tel Aviv, these are incredibly big cities with incredibly great universities and amazing hospitals. They're not in the top 10. Now, why is that? Why do we have all of the world's innovation, right? Like something like 30% happening in 3 cities. I don't know the answer to that, right? I don't really know why that is. Is it the case that you have to do it in those 4 cities? I mean, maybe. I find that hard to believe, but maybe. But if so, then we need to understand what is so magic about those 4 cities and prevent all these other cities from wasting their time trying to do the innovation, right? Or maybe there's something amazing about these 4 cities that we can export to other places. I don't know the answer to any of these things, but I think COVID certainly made me realize again and again, like how much of this R&D comes from the same universities, the same academic labs, and actually they don't need a lot of money. They don't need a lot of money to do a lot of the basic science research. So it might cost a ton of money to actually build a manufacturing facility to make a vaccine. But the real innovation here was discovery of mRNA as a target, then knowing how to build synthetic mRNA. And a lot of that R&D is like financed by $15 and $20 million grants to universities like yours and mine, right? So I think, again, we should be thinking about, can we widen the aperture? Can we think about, now, here's the weird thing about this. If I was running a VC, right? If I was a venture capitalist and I said to you, Ziad, 1 in 10 of my investments are successful, you'd be like, dang, Amitabh, you're just like a genius VC. But if I was Francis Collins and I went to Congress and said, only 1 in 10 of the dollars I gave all these universities resulted in a paper in Cell, they'd be like, oh, you're just doing a terrible job of picking research. So I think somewhere in this, I'd love to think about what is the organization that the United States needs to build to kind of create an NIH where Congress is not constantly asking the NIH director, what did you do for cancer in the last 6 months? I mean, this has got to be a marathon that kind of continues forever. I don't know how to create that, and one problem with not creating it is that NIH, going back to COVID, starts to think that its role is to subsidize clinical trials. This is like the worst thing for the NIH to be doing, right? Moderna has infinite access to capital markets. So the fact that the NIH came in, subsidized the clinical trial at Moderna is a colossal waste of taxpayer dollars. Colossal, especially given how expensive trials are in the first place. But it's a natural consequence of the peculiar position we've put NIH in. Congress will cheer NIH for having underwritten the cost of the Moderna trial. When really what we want is, some basic science discovery that might not even involve human beings. It might be in zebrafish.
John asked the question in the chat that I just wanted to put to you guys because I don't know the answer, but is the thing you're proposing, Amitabh, is this the HARPA that has been proposed?
I think the problem with the DARPA and the BARDA is it works for vaccines. I think all of these ideas that the president has are very good for a disease that is already here, like COVID or something like that. You have a problem, you have an enemy, you have to conquer and destroy the enemy. But what about just foundational discoveries in basic science, like the discovery of DNA, recombinant DNA, for example, that then sets up to discover CRISPR 30 years later, right? That's not sexy. And that's actually the opposite of investing in DARPA and BARDA. I think DARPA and BARDA are all about taking today's science and bringing it to market. That's fine. We need that for a handful of things. But for a lot of diseases, we are still in the petri dish. And we need more people getting more money to kind of stick to the petri dish, which is not the DARPA model.
I mean, I think Amitabh's exactly right. If it's easy enough for a congressperson to see why something's useful and it ought to be done, then it's also easy enough for capital markets to see why it's useful and ought to be done. And where we want the taxpayers' money spent is on the public goods that are foundational, and it's obviously not a profitable thing for a venture capitalist to do, but yet sets off a chain of wonderful discoveries that benefit everybody.
Yeah, I think, getting back to the spirit of what can the U.S. learn from elsewhere, this topic strikes me as something incredibly important of what can we learn from the places that are doing it well and keep doing more of it. But also, I mean, if we're thinking about from the policy perspective, it seems like back to the organizational or care delivery innovations that Fiona was talking about might be more the area where we can learn a bit more from elsewhere and how they're doing it, right? If you want to bucket things into the discussion we were just having is how do we get more good stuff to solve problems we don't know how to solve? This other organizational innovation or delivery innovation is just how do we take all the good stuff we have and use it to actually solve problems that we know we have, right? Which is a really simple version of that is what's happening right now with the vaccine, right? For example, and getting that delivered to everyone, right? And that's even it feels like it should be at least a simpler problem than the adherence of a 75-year-old grandmother who lives by herself and has to take 8 different medications many different times a day and so on and so forth. And so some of this, I think runs into, issues around, Ziad, I think you brought up that, just making things easy for people, right? Figuring out just discoveries that make things easy for people. It seem like they might have kind of more bang for the buck than we think. And I don't know, I think that's one of the really kind of cool things when I think about what's happened over the last year, in thinking about how we start to repurpose a lot of the things that we use to make life easy under quarantine and deliver things to people in ways that we never did before. And that seems to me to have a lot of analogs and potential applications in helping, my grandmother, be better adherent and healthier in her life, for example.
Yeah, I think that one of the amazing things that's happened is if you look at just the, not just the rise of telemedicine in general during the pandemic, but in particular, the therapy delivered over the internet. So just kind of regular basic psychology that's now accessible to anyone without needing to go in to see a psychologist. I think that's the kind of thing that could, if we're thinking about the long-term health impacts of the pandemic, I just think that this is one of the things that could end up being just transformative for millions of people. We know how underdiagnosed depression is and how hard it is to get people to kind of go see a therapist. And now you can just just like you watch a YouTube video, you can actually talk to someone and learn all of these things. I think that this actually is like one of the potentially huge long-term benefits of this. Amitabh, did you have a point on that?
Yeah, I wanted to put together this point you're making with what this point about testing that you were all making. We were talking about testing in the context of COVID, and if you look at cancer and you look at what we have for testing or detecting cancer, smears, pap smears, colonoscopy, mammograms, these things were all developed in the 1960s. And which is why the US Preventative Task Force says they're kind of rubbish, right? They have like incredibly high false positive rates and things like that. The advances in molecular biology have not really made it to the detection of cancer. But there's this interesting kind of interplay between innovation and regulation. I think right now, and I'm thinking of Heidi Williams's work, pharmaceutical companies have a strong incentive to make drugs for metastatic cancer and recurrent cancer because, I'm not eating into 20 years of patent life. I have to do a 3-month clinical trial. And of course, everyone in society would much rather just not have the cancer or have it caught stage 1 and have it treated with, say, surgery and radiation in stage 1. But we don't know how to catch it well in stage 1. Our thinking is, well, if I do colonoscopies, then I'm going to, falsely say people have colon cancer. So I think on testing these ideas, and I'm not affiliated with these ideas in any way, but it's made me wonder whether the innovation we really need is things like liquid biopsies. And I don't know if the liquid biopsy, I'm not going in the Theranos direction, but that is the kind of idea that would actually reduce the pressure to innovate in expensive drugs, because the current armamentarium is a lot more effective in a patient who has stage 1 cancer. It's completely ineffective in a patient who has stage 4 metastatic cancer. Stage 4 metastatic cancer, we need just more stuff, but we're just fighting biology because of resistance. And so I think there is that interplay is a place where one of the things that I'm excited about, that I'm seeing for the first time, is the US FDA has been a sleeping giant, but has in the past 10 years issued very quiet guidance to companies on what it would take to get one of these novel tests approved. And that reduces the hurdle that they have to cross, because you're giving them ex-ante guidance on what they need to show. I think that's very exciting, because then we'll have better tests. We won't need to kind of produce all of these drugs that cost a ton of money, but only generate, as Fiona said, 6 days of life, right? That's not what I want.
Yeah. So that those tests are close to being available. There's a company called Grail that claims to be very close to releasing a test that does what you're describing. You take a blood sample, and then it's exactly as you were saying, building on gene sequencing. You look for the sequences that are cancer, and those turn out to be present in your blood at these earlier stages. And so it's exactly what you're saying. You can catch stuff earlier, and that of course is going to save lives and reduce the need for these painful and not so effective later treatments. So it's pretty great. It's an exciting moment.
I think I'll add that I'm very optimistic on the potential for machine learning to help there. I think, we often get an X-ray or an MRI or a biopsy specimen, and our current technology for processing that, for making sense of it, is by showing it to a human. As we start to get data sets that link these very complex high-dimensional objects to long-term outcomes, we're going to do much, much better in actually being able to process those things. And I'll mention one effort that might be interesting to people here in that regard is this nonprofit that I started with my co-author Sendal Mulanathan at Chicago, which is essentially working with health systems. So we have a lot of philanthropic funding. We work with health systems to build up those exact data sets. So slide specimens, a link to these long-term outcomes. They get to keep that and do whatever they want with it, but we get a de-identified version that we take out of the health system, put on our cloud, and make available to researchers. And so I think that's exactly the kind of work that I think is going to be transformative, but you need the data to do it. and that's the problem we're trying to solve. There are a couple of really great questions in the Q&A, and we've got 5 minutes left. I wanted to just get to one or two. There's one that David Levine asked that I think is a really excellent question, which is, I think, back to the point you made, Amitabh, about drug adherence, which is, why can't pharmaceutical companies capture the value from better adherence? It seems like a very obvious thing to do. Like, why don't they just make the drugs taste great? Like,
yeah. I think pharmaceutical companies are very good at capturing the benefits of a superior, formulation that is easier on adherence. Atripla, that I don't know who makes Atripla. Gilead makes Atripla, I think. It's an old, from a chemistry point of view, it's just taking like an NNRTI and an RTI, combining them. And now we've got this thing called Atripla, but it makes the adherence demand on the HIV patient much easier, right? Now, I think the problem I have with Atripla is not that they did Atripla. It's not clear to me that you should now get the 3 years of exclusivity. So that kind of comes back full circle. We can from time to time over-incent some of these innovations. Like, maybe on the back end, we have to think harder about, and this will probably get me in a lot of trouble, but like in the orphan drug space, I've always thought you need some heavy price regulation, because some of these, I'm jumping from adherence to orphan drugs, I'm aware of that, but I'm trying to get at this point that you don't want it to be the case that either in the Atripla case, Gilead does a hard switch to everyone on Atripla and stops making the earlier formulation, because now society is forced to pay the higher price for a drug when it was happier with the older drug. But in the orphan drug space, where you have drugs that literally target 50 people a year, even when all the patents expire, there will be no generic entrant, because this is a natural monopoly. So we have to get ahead of this problem before it starts. In 5-10 years, a lot of these gene therapies will be ready for competition. There will be no competition. A single firm will be able to kind of meet the entire market. We're going to have to think about price regulation of those drugs. And I don't know if we've actually begun to do all that. And I'm hoping that Matt and Fiona are the people who are thinking about how to do that. I'm good at sort of saying, well, there's a problem, but then we need ultimately an IO economist to come in and say, here's how I would price regulate those kinds of markets.
It's an IO emergency. If anyone's listening, we need a stat IO consult. Let's see. So there's one. Jaime Perez asks about the implications of of Mariana Mazzucato's work for, how we should be thinking about incentivizing and supporting innovation from the government side. And I thought maybe that could be a good place to end, because I think we've only got 3 minutes left. And so I think, we talked, of course, about investing in basic research, even if you don't know what you're investing in, that's just going to pay these huge dividends down the road. But I think there's also this, other model, which is the DARPA, or maybe like the moonshot model. That I think that the problem with a lot of those model, I see Ben agrees that we need more IO in the chat. Thanks, Ben. One of the problems with the moonshot model applied to healthcare is that the moonshot model had a very clear goal: get to the when we have a cancer, I forget what we're calling it, not moonshot, whatever it's called. It's like, what is the measurable, and how do we know that we've gotten there, and what are we incentivizing exactly, as opposed to getting to the moon? There's some really interesting work about how NASA shifted from a moonshot model to a market regulation and innovation model. But I wanted to just give you guys a last word on, thoughts on that general direction. Crickets.
A very quick thought is, we spend a lot of time talking about patents and exclusivity periods. We should think also much more, we should think about R&D tax credits. I think they're much cheaper. I think they can induce a lot of innovation. I think small firms are more cash strapped than big firms, so R&D tax credits might work. I think we should think about the workforce. We never talk about the workforce. The workforce is so in immigration policy for high school immigrants who do this kind of work, profoundly important for innovation. We saw that with the mRNA vaccines. We saw, it was built by immigrants.
Yeah. And I'll chime in and say we should also think about merger policy. That I think if you want diversity of approaches, if you want really a lot of different ways of attacking a problem, organizational econ tells you you can't really put all of those inside the same company. That they're gonna be managed by somebody who sets resources according to what they believe and not the 17 different ways underneath them. You really need 17 different companies if you're going to have 17 different approaches, scientifically or based on beliefs about demand or costs or something. So I think we have to watch our merger policy too.
Yeah, and I think the only thing I would add is just this issue of building data sets. Like Ziad, I think, had a great example of the initiative that you have. Is just I can't emphasize it enough, because I think, you know, there's no way to know really what's really working or not working unless we're building these longer term data sets that are connecting things to outcomes and giving us, you know, larger, longer term data sets. And so I think that's going to be a key feature of any success or, you know, a lot of particular successes in healthcare over the next decade or two.
On that note, Matt, Amitabh, Fiona, thank you so much. I have learned a ton and really enjoyed the discussion. Thank you.